Good morning. Today I'm going to present the forearm instability, anatomy, biomechanics, and treatment option. When we talk about forearm instability, this is a very rare topic because mostly we are tackling the wrist joint or the elbow joint. But today I'm going to report the forearm instability. They said that radial head is the weight-bearing joint. So they are the primary of the forearm in weight bearing. So the radial head is responsible for this. And the interosseous membrane is not actually discussing in every topic that you attended in elbow course or in the wrist course. So I'm going to tackle mostly of the interosseous membrane because this is the one who gives the stability of the forearm joint, which is this one, and the osseous membrane can be seen from in between of these both, the radius and the ulna. One of the most important function or the IOM is the stability of the longitudinal axis of the forearm. It means it is the responsible holding these two together, whichever movement of the forearm it goes, like in pronation and in supination. So it has different parts. It has a dorsal oblique band and the central band, which is the most important. And then there's a dorsal oblique accessory, and there's also an accessory band, and it has a proximal oblique cord. So this osseous membrane is responsible holding these two bones, the radius and the ulna. As you can see here in the next picture, it's written in the green arrow, the interosseous membrane. Mostly the injury happen patterns are scoliosis is the one of them, and it has also one more is the notational injury. And in watching this video will give you the whole idea of scoliosis fracture.
This fracture may be short, oblique, or transverse. It involves fracture at the junction of the middle third and distal third of the radius, with associated injury to the distal ulnar joint. The closer the fracture is to the distal radial ulnar joint, the more likely that it will be unstable. Dislocation of the distal radial ulnar joint is usually dorsal. It may be associated with either a ligamentous injury or fracture of the styloid process of the ulna. The fracture is usually located above the proximal border of the pronator quadratus muscle. The distal fragment usually moves towards the ulna. Scoliosis fractures are best treated with open reduction and internal fixation of the radius and assessment of the distal radial ulnar joint. Surgery is necessary. Non-surgical treatment in adults usually results in recurrent dislocations of the distal ulna and a bad outcome.
Okay, when they talk about scoliosis fracture, the scoliosis fracture, they name it also a necessity fracture because if you have this fracture, it's necessity to do the surgery, the open reduction, and aside from that, you must take care of the dearrhythmic joint as well as the fracture of the styloid of the ulna. What are those structures? In dearrhythmic, they are responsible for stability of your joint. And then, when you talk about the styloid of the ulna, that's the insertion of the TFCC, which is also responsible for the dearrhythmic joint. Now when we go to the next fracture, the montigial fracture. This fracture is involvement of the ulna proximally. It's different from Galeazzi. The Galeazzi is in the radius, distal radius. And then the Montilla fracture is from the ulna proximal. As you can see here, this radial head, it should be situated in the radial facet. That's why it has the fracture of the ulna plus dislocation of the radial head. The Montilla fracture dislocation. You can see here in the video the full understanding of Montilla fracture. So in Montilla fracture, it's also needed to evaluate. Because if you don't evaluate, there's a dislocation of the radial head. And in dislocation of the radial head, you have to either check the annular ligament for stability. Because annular ligament is responsible for the stability of the proximal radio-ulnar joint. And it has 4 types. The body classified into 4 types, the Montilla fracture dislocation. There's a type 1, type 2, type 3, and type 4. As you can see in the video, Montilla fracture dislocation here in type 1. As you can see, it has a fracture of the ulna plus dislocation of the radial head. And this is the most common type. And it's about 60%. So in type 1, as you can see, the radius dislocated dorsally. Now in type 2, the radius dislocated dorsally. Type 1 is the radius dislocated volarly. And the same fracture, the ulna, and it's the less 15% only. And in type 3, he classified the position how dislocate the radial head. Here it dislocated laterally. And the dislocation also, and the fracture still in the ulna, but the head of the radius dislocated laterally. In type 4, the fracture is not happening only in the ulna, it also happening in the radius, and the radial head is dislocated also volarly. What is the importance of this one? We need to learn those dislocation, because in splinting, it based on how dislocated the radius, how you will position and split the elbow. So, on the point of view of the doctor or the dentist or the orthopedic, mostly they do a plate and screw repair or fixation, and they also, if the radial dislocated, they need to check also the annular ligament for repair, or it is necessary to repair, because annular ligament is responsible for the stability or of the radioulnar joint. Okay, when we talk about longitudinal instability or the Lopresti injury, this is the importance of the osteointerosseous band, because osteointerosseous band is responsible for the stability of the forearm bones, the radius and the ulna, to stabilize in this manner. It won't goes up or it won't goes down. It has a two classification, the type 1, the type 2, and the type 3. As you can see here, this is a type of injury also, that the dislocation happened in the distal VRUJ, as well as a fracture, and it also involved the radial head fracture. And in type 2, it has a fracture of the ulna plus dislocation of the radius. And in type 3, it has also the dislocation of the VRUJ plus fracture of the ulna radius in proximal part here. Here are the video where I'll show you the Essex Leprosty injury.
There is a Mason classification. Type 1, non-displaced, no block to the forearm rotation. The treatment is early motion. Type 2, displayed.
So here's another classification of the Essex Leprosty injury, which when we talk about type 1, it's only a small portion or a chip fracture of the radial head. So if there's a fracture of the radial head, insignificantly need any surgery.
Is more than 2 millimeters, and the treatment is usually fixation.
So in type 2, they're talking about the size of the fracture here. It is greater than either 1/3 or almost a half of the head, of the radial head. So it needs a fixation for that.
Type 3, comminuted, displaced, irreparable.
And when they talk about the shattered fracture of the radial head, which is you cannot repair that, so mostly what they are doing, radial head arthroplasty. They will change the whole head of the radius. It's either the metal head, or they use also a silicone, but they said silicone is not reliable, so they use only the titanium head.
And the treatment, usually replacement. Replacement will be with a metallic modular prosthesis. Excision alone can be done in some situations. It is rare, but before you excise the radial head, you must make sure all ligaments are intact, that you examine the patient, and there is no distal radioulnar joint injury or elbow injury. So if you have a patient with a comminuted radial head fracture, it's probably safer to replace it. Type 4 is a fracture of the radial head associated with dislocation of the elbow joint.
So why they need to repairable head, why do you need to change the head? Because remember, as I discussed before, the radius is the weight-bearing joint, the weight-bearing bone. They are responsible for weight bearing, and if there is any changes of the height of the radius, the loading in the wrist area will be changed as well.
The treatment is usually a temp reduction of the elbow joint with fixation of the fracture, or excision of the radial head and prosthetic replacement if the fracture is unreconstructible, cannot be repaired. Excision of the radial head alone is contraindicated in elbow dislocation, or in essence, the prostate fracture.
So in treatment, they said there's no universal consensus upon the optimal treatment of the acyclic breast injury. They said in acute setting, they said mostly this is not evaluated well. They do only X-ray, and if they say a fracture, they are not thinking about the soft tissue injury, which is the responsible for the stability of the forearm joint, the interosseous membrane. In the unreconstructible radial head, it was discussed, it needs to be changed by the radial head, or the called radial head arthroplasty. And that's why there's a chronic setting which is neglected. Yes, they do the fixation, but they did not repair the soft tissue. So the pain is still there in the forearm, which the patient complained. And in prosthetic radial head replacement, this is also one treatment which is good, especially for the shattered of the radial head. Direct repair is a must, because if you have already detected that it has a acyclic injury, if you repair the soft tissue as well as the bones, the prognosis is good. And in augmentation or reconstruction, it means this is already a established procedure. It means they detected this injury long time ago injury, and they only detect now because the patient complained of the pain. So what they will do is either they release the interosseous membrane, or they will repair it with other ligament. So mostly, if there's a ultimate salvage procedure because of complaint of the pain in forearm or unstable forearm. So for the complication of this procedure, they said a high reoperative rate anticipated for sacrifice of forearm rotation, functionally limiting. Because mostly after the surgery, they put the forearm not in neutral position. They either put in supinated or in pronated, which is the functional position of the forearm is in neutral, which most of the ADL is happening in neutral position. So in conclusion, treatment options have been proposed for the forearm, ranging from observation. They check the interosseous ligament repair. Then you have to immobilize with either pinning or orthosis. And then by split, this is where the occupational therapy, especially the hands unit, will fit in and do the rehabilitation, because short arc motion is the most important in every repair of the forearm or any injury. The treatment of forearm axis instability is addressed with stabilization of DRUJ here, and the proximal radio-ulnar joint, because this joint will happen the pronation and supination. And thank you. Thank you. Any questions? Okay.
Based on your presentations in Galeazzi fracture, you said that there is fracture on your radius plus dislocation of DRUJ. So why is it important to stabilize the fractures, and what positions that we need to keep the patient in this limb?
As a point of view, as occupational therapy enhanced unit, you have to position your elbow first in 90 degree to prevent pronation supination. The split is called the sugar thumb split, and you have to position your wrist in neutral, and the pronation and supination also is in neutral. So it's positioned like this: 90 degree in elbow, pronation supination neutral, and the wrist is neutral to prevent the pronation and supination to establish the stability for healing.
Second question.
Okay.
Why is it important to do a radial arthroplasty in your head?
Before, when they have a unrepairable radial head, they just cut the head and throw it in the garbage, as Shrikant said in his last presentation. But it is important to maintain the length of the forearm, because if you don't maintain the length of the forearm by putting the head arthroplasty, there will be imbalance of the loading in the rest joint, which is the radius carrying 80% of the load, and the ulna is carrying 20%, which is disturbed if the length of the forearm is not in anatomical length or position. Thank you very much.